Good morning. Myself, Dr. Vani from Department of Pharmacology. Today we will have a lecture on drugs for epilepsy. So the learning objectives include at the end of the lecture, student will be able to explain what is epilepsy, what are the types of epilepsy, mechanism of action, uses, newer anti-epileptic agents, status epilepticus, and special points. Medical condition produced by sudden changes in the electrical function of brain. It is a condition characterized by recurrent episodes of seizure. So a seizure is a paroxysmal abnormal discharge at higher frequency from neurons in the cerebral cortex, whereas convulsions is an involuntary jerky movement and spasmodic contractions of the skeletal muscles. An abnormal discharge at higher frequency from the cortex of the cerebral cortex, whereas convulsions is the involuntary jerky movements, spasms about the typical jerky movements of the limbs, frothy saliva, blinking eye, along with tonic and clonic contractions. So deficit infections like meningitis, brain abscess, concussions, depressed skull fracture, brain tumor, drug withdrawal like CNS depressants, and in children, hypocalcemia and photoepilepsy. Coming to the drugs, so there are certain drugs on stoppage which can cause epilepsy. So the drugs of abuse like amphetamine, cocaine, phencyclidine, methylphenidate can cause epilepsy. That is, can cause seizure on stoppage. Anesthetic agents like meperidine, tramadol, and local anesthetic can cause seizure on sudden withdrawal. Psychotropic agents like antidepressant, antipsychotic, lithium can cause seizure on stoppage. Sedative and hypnotic drugs like alcohol, barbiturates, and benzodiazepine on sudden stoppage, these drugs can also induce seizure. Coming to the classification of seizure. So seizure is classified as generalized seizure and focus seizure. When we mention it as generalized seizure, the whole body might be involved. Multiple areas of the brain is involved. That is why we call it as the brain is involved. So based on that, we will classify them as simple seizure, complex seizure, and simple, complex, partial seizure with secondary generalization. Types one is the absence seizure, myoclonic seizure, tonic-clonic seizure, and atonic seizure. This generalized tonic-clonic seizure occurs for 70 to 80% of the cases. Three types of partial seizure, simple partial seizure. In this, the electrical discharge is confined to motor area, whereas complex temporal lobe along with mood disturbance. Whereas primary generalized seizures, we have five subtypes. One is tonic, and we have tongue bite, and may lose the bladder control and bowel control. Whereas tonic seizure patients have dropping of consciousness. So here there will be a minimum momentary loss of consciousness, whereas the unconsciousness and the relaxation of patient's muscle is seen. And in myoclonic seizure, there will be a sudden brief shock-like contraction of the muscles of the extremities is noticed. Whereas absence seizure, we call it as petit mal seizure area. Most common children between 4 to 12 years of age. Here the typical EEG pattern would be 3 Hz spike and wave pattern. And the last one is the recurring seizure. We call it as status epilepticus. If the seizure episodes last for more, we classify the seizure as status epilepticus. Coming to Lennox-Gastaut syndrome, this commonly occurs in children and is defined by the following triad: multiple seizure episode with EEG of less than 3 Hz spike and wave pattern, impaired cognitive function, which is associated with CNS disorder and CNS disorder. It's characterized by a hippocampal cirrhosis. This is a refractory to treatment with anticonvulsant agents. So this is a pictorial representation of partial seizure. Primary, you can see the partial seizure or the focus seizure. Particular area of the brain is here, the temporal lobe is involved. So the occipital lobe is involved. And in this picture, whereas partial seizure with secondary generalization. So initially the occipital lobe of the patient is involved along with the seizure with secondary generalization. Coming to the mechanism of action of the drugs. So the prolongation of sodium channel inactivation is done by the following: lamotrigine, topiramate, and zonisamide. Facilitation of barbiturates, benzodiazepine, vigabatrin, valproate, gabapentin, and thiagabine. Inhibition, trimethadone, and valproate. So here there are few drugs which has multiple mechanism of action. These such drugs include phenytoin has dual mechanism of action, sodium valproate, lamotrigine has dual mechanism of action. Let's see it one by one. So this is the picture. So you can see this. The drugs will go and bind to the receptor binding site, and it will prolong the inactive state. So sodium channel will remain inactive. So this is the normal thing of sodium channel. So this will maintain it in the inactivated state. So this is a picture explains about the facilitation of GABA mediated chloride channel opening. So you can see this. Can you see? So this is the site where your benzodiazepine will go and bind, and this will cause hyperpolarization. So it will prolong the chloride channel. So this prolongs the GABA mediated chloride channel opening. Okay, so this is the mechanism of action of benzodiazepine as well as barbiturate. The mechanism of action is similar, only the binding site is different for benzodiazepine as well as barbiturates. Your tiagabine will go and bind to GAD receptor and prevents the passage of GABA, whereas bigabatin and valproate goes and binds to the GABA transaminase enzyme and prevents the conversion of GABA. So this in turn facilitates the GABA mediated chloride channel opening. Coming to the third subtype, inhibition of T-type calcium current. So this drugs like valproate, ethosuximide prevents the entry of calcium ion across the membrane. So this in turn prevents the further muscle contraction, skeletal muscle contraction. Coming to the drugs of choice. So in the left side, I have given the type of seizure. In the right side, I have given the drug of choice and alternate drug of choice. So let's see it one by one. So for tonic-clonic seizure or the grand mal epilepsy, the drug of choice, the alternative drugs include carbamazepine, phenobarbital, and phenytoin. Whereas for carbamazepine, phenytoin, and valproate, the alternative drugs of choice include phenobarbital, lamotrigine, or gabapentin. Whereas for absence seizure, the probably ethosuximide is preferred. Whereas for alternate regimen for absence seizure include clonazepam or lamotrigine. For my valproate, and the alternative drug of choice is clonazepam. And for status epilepticus, we always start with lorazepam, followed by diazepam, followed by fosphenytoin, followed by phenytoin, followed by phenobarbital. If the patient is not responding to phenobarbital, then we will sedate the patient with either thiopentone sodium or propofol. For febrile seizure, we usually give diazepam in intrarectal route. So we'll keep the diazepam for the baby rectally and we'll see for the temperature and we'll monitor the baby for next 24 to 48 hours. Sodium valproate. Come to the treatment, important points to be remembered in treatment. Up to 80% of seizure with appropriate treatment. Anti-epileptic drug suppresses but does not cure seizure. So basically, we cannot completely cure the seizure. We can keep the seizure under suppressed state. Anti-epileptic drugs are indicated when it's to 1 year of age. In that case, we are supposed to continue. And initial therapeutic aim is to only use one drug. So we usually start with monotherapy. If the patient is not having an advantage with monotherapy, then we'll go for combination therapy. Decreased drug interaction, better compliance to the patient, and lower cost. Addition of secondary drugs likely to result in significant improvement only in 10% of the. So if at all patients require a multi-drug therapy, then only we will add multi-drug therapy. Otherwise, we will go for single drug therapy. So when the total daily doses increase, the sufficient time about 5 t-hours should be allowed for the serum drug level to be reached for a new steady state plasma process. Because there are certain drugs like phenytoin are coming under lower or narrow therapeutic index drug. So for these drugs, we have to wait for the completion of 5 t-hours. Then when this new steady state level is reached, then we can give the new dose. So all this has to be taken into account. The drug is usually administered orally. Monitoring of plasma drug level is very useful. Precipitation and the aggravation factors can affect the seizure controlled by the drugs. Sudden withdrawal should be avoided because sudden withdrawal, even the anticonvulsant drugs can cause seizure. Okay, and relapse rate of antiepileptics after withdrawal is 20 to 40%. That is why we always make sure the patient is having a minimum of 6 months to 1 year of epilepsy-free interval and minimum 2 years without seizure. Then we will consider of stoppage of or reducing the dose of antiepileptics. Coming to the epilepsy and pregnancy, seizure is very harmful for pregnant female. Monotherapy is usually better than combination therapy for every pregnant female with epilepsy. And there are some drugs which are completely contraindicated in pregnancy. In anti-epileptic drugs, the drugs are phenytoin, sodium valproate, and barbiturates also to some extent contraindicated in pregnancy. These drugs comes under carbamazepine. And there are new epileptic drugs which are also under trial for pregnancy. And still, we don't have much reliable reports for considering it as a drug of choice. The safer anti-epileptic drugs in pregnancy include carbamazepine, oxcarbazepine, lamotrigine, and ethosuximide. This lamotrigine and ethosuximide comes under second generation and first generation anti-epileptics. So this should be given along with folic acid supplementation. So when to withdraw the anti-epileptic drugs? So the withdrawal of anti-epileptic drugs only should be considered when the neurological examination, EEG prior to withdrawal is normal. Seizure-free interval at least 3. So we consider it as 2 to 3 years of seizure-free interval and no juvenile myoclonic epilepsy. If the patient is having juvenile myoclonic epilepsy, he or she has to continue the drugs lifelong. Otherwise, we can consider stoppage of drug therapy. Coming to the individual agent, phenytoin. So phenytoin, we already saw the mechanism of action. It causes membrane stabilizing effect by blocking the sodium and calcium influx into the neuronal axon, and it also inhibits the release of excitatory amino acids via inhibition of calcium. So basically, your phenytoin inhibits the sodium and calcium ion influx across the cell membrane. So what are the clinical uses of phenytoin? So basically, phenytoin is used for two types of seizure. One is the partial seizure, the other one is generalized tonic-clonic seizure. It is not effective in absence seizure. So as we saw already in the classification, for absence seizure, the drug of choice is ethosuximide. And preferably, valproate can also be used if the patient is not effective. But the preferred agent for generalized tonic-clonic seizure, we start with either sodium valproate or phenytoin based on the age of the patient. And it is also used for treatment of ventricular fibrillation. Coming to the pharmacokinetic profile, it is well observed when it is given orally, but it is also available as IV. In case of emergencies like status epilepticus, phenytoin will be given as IV. It is a very big enzyme inducer. This is a very important one because this enzyme inducing property plays a key role for failure of many important drugs. So when a patient is on phenytoin therapy, we are supposed to be conscious in certain drugs like warfarin, OCP. All these drugs will have failure of therapy when it is combined with phenytoin. So we have to be conscious when patient is on phenytoin therapy. And metabolism shows saturation kinetics, hence the TF increases with dose increase. So when increasing the dose, this drug follows saturation kinetics. So if you're increasing a dose to a minimum extent, the effect will be very narrow. And this also is a narrow therapeutic index drug like lithium. So you're supposed to consciously give the dose in a very important required dose for the patient. And the excretion usually occurs in the form of urine, DRs. The therapeutic plasma concentration of phenytoin is 10 to 20 micrograms per ml, which is a narrow therapeutic index agent, and the dose should not exceed more than 400 milligram per day. GIX, neurological effects like headache, vertigo, ataxia, diplopia, nystagmus, sedation, intimal damage, thrombosis of vein, which can be seen at a rate of less than 50 milligram per minute. Effects include hyperplasia of the gingiva, hirsutism, hypersensitivity in that case, hydantoin syndrome. This is seen when a pregnant female consumes phenytoin. This can end hypoplastic phalanges and microcephaly. Bleeding disorders is commonly seen in infants. Osteomalacia due to abnormalities in the vitamin B metabolism and megaloblastic anemia. Who was treated with 300 milligrams of phenytoin for 2 years, and after this, patient was stopped with phenytoin therapy and he was given sodium valproate and patient recovered. So after 3 months, you can see a partial recovery of the gums. So when the patient develops gingival hyperplasia, we are supposed to abruptly stop the therapy and give the alternate drug regimen and monitor the patient regularly. And the other pharmacokinetic profile, as I told, it has a very big enzyme interaction. So inhibition of liver enzyme elevates the plasma levels of the big enzyme inducer as well as inhibitor. It induces the liver enzyme, decreases the plasma levels of carbamazepine and rifampicin. Rifampicin is an coming to carbamazepine. So the mechanism of action and the clinical uses are similar to that of phenytoin. So this also interferes with calcium and sodium passage across the cell membrane and prevents the neuronal transmission. So one major advantage of carbamazepine include this can also be used in treatment of trigeminal neuralgia. Trigeminal neuralgia, the drug of choice is carbamazepine, and in mania, carbamazepine is used as a second-line drug of choice. This is only available in oral format, well absorbed orally. It has 80% plasma protein binding property. In phenytoin, we saw it had 90% plasma protein binding property, whereas carbamazepine has 80% plasma protein binding property. It also has strong enzyme-inducing effect. So this also causes failure of OCP therapy and warfarin therapy. Metabolism is also done by liver. Coming to the other pharmacokinetic parameters, excretion occurs in urine as a glucuronide conjugate. Plasma T-half is 30 hours, which means concentration for carbamazepine is also 6 to 12 microgram per ml, which is also narrow, and the daily dosing rate should not exceed 800 milligram per day. So we'll be giving it as twice a day regimen as sustained release formulation or as an alternate therapy based on the patient's need. Drowsiness, hepatotoxicity, rare. Congenital malformations here include craniofacial anomaly, and neurotube defect. So this drug is also completely contraindicated in patient. So for the patient who are on carbamazepine therapy, the intake of water should not exceed more than 3 liters per day. And the late hypersensitivity reactions include erythematous skin rashes, mouth ulceration, epilepsy anemia. So there we saw for phenytoin it causes megaloblastic anemia, whereas carbamazepine causes aplastic anemia. Coming to the other pharmacology, it elevates the plasma levels of phenytoin, phenobarbital, and rifampicin, which can end up in drug failure. It inhibits the liver enzymes and elevates the plasma levels of. This can cause toxic effects of the drug. Coming to phenobarbital, the mechanism of action is it increases the inhibitory neurotransmitter, that is gamma aminobutyric acid, and decreases the excited neurotransmitter. So basically, we are decreasing the excited neurotransmitter and we are increasing the inhibitory neurotransmitter, because excited neurotransmitter causes excitation, which can end up in seizure discharge. So we are decreasing the excited neurotransmitter and we are increasing the inhibitory neurotransmitter like GABA, which causes depolarization and increases the chloride ion conductance. Coming to the mechanism of action of sodium valproate increases the GABA content of the brain, inhibition of GABA transaminase and succinate semialdehyde dehydrogenase. The other one more mechanism of sodium valproate include it also inhibits the T-type cathode. This is why we call valproic acid as a broad spectrum anti-epileptic. So this can be asked as an MCQ in NEET. So which of the following is a broad spectrum traditional anti-valproate? Because it has multiple mechanism of action. It blocks the GABA. It increases the GABA-mediated chloride channel opening. It blocks the T-type calcium channel. That is why we call it as broader spectrum. Pharmacokinetics. It is available as capsule. Occurs in the liver. The metabolite gets converted to inactive metabolite. This drug also has higher oral viability. This also has an enzyme-inducing property and inhibition property, and it inhibits the metabolism of drugs like carbamazepine, phenytoin, topiramate, and phenobarbital. So that is why this should not be used unnecessarily. And the excretion occurs mainly through urine by glucuronide conjugation, and T-half is 12 hours, 12 to 15 hours. Clinical uses. So it is a very effective and generalized drug. So basically for all types of seizure, this drug is preferred, except partial seizure. For partial seizure, carbamazepine. So the side effect profiles of sodium valproate include nausea, vomiting, GI disturbance. So that is why we always start with low dose, and it also increases the appetite and weight gain. So you should consciously use in patients who are obese. It can cause transient hair loss, hepatotoxicity, thrombocytopenia, and the neurotube defects which is seen here is spina bifida. This drug also comes under category X drug for pregnancy. Coming to newer drugs. So how we can use the newer drugs. So why newer drugs lack the drug-drug interaction with a simple pharmacokinetic profiling and improved tolerability. This drug have a wider safety margin compared to people are preferring second generation over the traditional first generation drugs. But the one major disadvantage is these drugs are costlier. Also known as newer antipsychotic drugs. So the drugs are vigabatrin, gabapentin, lamotrigine, toxcarbazine, and zolpidem. Let's see individual drugs. Lamotrigine. So lamotrigine has a pharmacological effect similar to phenytoin. So in mechanism of action, what did we see? Phenytoin, calcium ion and conductance as well as sodium ion conductance across the cell membrane. This drug also blocks the GABA and glutamate. So GABA and glutamate are excitatory neurotransmitter, which plays an important role for seizure discharge. This is prevented by binding of these drugs. It is well absorbed orally from the GI tract. Metabolism is by glucuronide conjugation, main advantage over sodium valproate. Okay, but one disadvantage here is when lamotrigine is combined with valproate, the mechanism of valproate is affected. So this should not become. It is used as an add-on therapy or as a monotherapy as well. Coming to the side effects. The side effects of lamotrigine are skin rashes, somnolence, blurring of vision, diplopia, light syndrome. Coming to gabapentin. Gabapentin is a structural analog of GABA. This increases the activity of GABA or inhibits the reuptake of GABA. So basically, these drugs are GABA mimetic drugs, which inhibits the reuptake of GABA or increases the activity of GABA. Pharmacokinetic profile of gabapentin includes it does not have much plasma protein binding property, neither metabolized nor excreted unchanged in urine, doesn't inhibit or induce the drug metabolism enzyme, that is your cytochrome P450 enzyme. So this can be used as a additional drug of choice with first line drug with the plasma T half of 5 to 7 hours. The side effects of gabapentin include somnolence, dizziness, ataxia, fatigue, nystagmus. The uses of gabapentin includes, as I already told you, since it doesn't have much important effects like unnecessary effects, like doesn't involve the cytochrome 50 enzyme, it doesn't induce identity enzyme, it doesn't have drug interaction, so it can be used as a add-on agent, and it is the main drug of choice for pain due to diabetic neuropathy and post-herpetic neuralgia. Coming to the next drug, sodium channel, which has membrane stabilizing property and also potentiates the inhibitory effect on well absorbed orally. It has 80% absorption in orally. It doesn't have effect over food, so food doesn't interfere with absorption of top pyramid. It doesn't have effect on microsomal enzymes. Cytochrome 450 enzymes are not neither induced nor inhibited. It has a minimum plasma protein and mostly excreted unchanged in urine with a plasma T half of 18 to 24 hours. So this drug also has a T half of 24 hours. Coming to the side effect, it can affect weight loss, sedation. So this weight loss can be used as an additional advantage in obese patient with seizure. Sedation, this is one major concern in dopamine, paresthesia and teratogenicity. Teratogenicity was noted in animals, not yet in human, but to be on the safer side, topiramate is not preferred. Vigabatrin is currently not openly available for everyone. It is for restricted only for infantile spasm. Mechanism of action of vigabatrin include it inhibits the GABA-mediated metabolizing enzyme, increases the GABA content in the milk. So basically, the drug makes GABA metabolizing enzyme GABA transaminase. So this GABA transaminase is inhibited by vigabatrin. So we already saw in the picture GAT. GAT is nothing but GABA transaminase. So this enzyme is inhibited by vigabatrin, not metabolized or excreted unchanged in urine, which has a T half of 4 to 8 hours. So the side effects include visual field defects, psychosis, and depression. That is why it is of limited use. So this is only used as a drug of choice for infantile spasm. It is not used for children below 2 years of age. Coming to zonisamide. Zonisamide mechanism of action, it may the pharmacokinetic profile include well absorbed orally. It has almost 100% oral absorption, metabolized in the liver. It doesn't have effect on the liver enzyme with the plasma T half of 50 to 68 hours. Clinical uses include zonisamide is used as a additional drug of choice for seizure. The side effect profiles include drowsiness, ataxia, headache, loss of appetite, nausea, vomiting. Gabapentin is used additionally as a add-on therapy for partial seizure and generalized clonic seizure. This also has a similar mechanism of action to your benzodiazepine. So it inhibits the GABA uptake and increases its level bioavailability of 90%, highly plasma protein bound around 96%, metabolism in the liver with the plasma T half of 4 to 7 hours. Coming to the side effects, asthenia, sedation, dizziness, memory impairment, and abdominal pain. Coming to what are all the clinical advices you tell them. So basically, if a seizure patient comes, there are certain things you are supposed to notify the patient. So what are the things you'll be telling? So you'll be considering, so in this case, it is very essential to have an accurate and comprehensive diagnosis. So how you'll diagnose a patient is having a seizure or not? We will take the detailed history of the patient. We will do electroencephalogram, that is EEG. Based on the pattern of EEG, we will go for drugs. We usually start with a single drug therapy. If the patient is not responding for single drug therapy, then we will go for multiple drug therapy. And we should also treat the underlying causes like hypoglycemia, infections, and tumor. And diagnosis should be made, and we have to tell the patient as well as the attendant, that is a bystander, about the detailed management plan. So this is the outline of status epilepticus. So can you see? So initially a patient will present to you in the OPD or casualty with the seizure episode which is lasting for more than 30 minutes. So here what you'll do, initially you will be giving lorazepam at a dose of 0.1 to 0.5 milligram per kg IV over 1 to 2 minutes, and the second dose will be repeated after 5 minutes. After giving this first dose, you'll wait for 5 minutes and you'll repeat the second dose. Even after this, if the patient is not responding, then you'll go for diazepam. Diazepam will be given. If the patient is not responding for diazepam, then you'll go for phosphenytoin therapy. If the patient is not responding for phosphenytoin at a dose of 20 mg per kg IV or phenytoin at a dose of 20 mg per kg IV at 50 mg per minute, if the patient is not responding, if the seizure is continuing, then you'll repeat the next dose at 7 to 10 mg per kg IV. If the seizure is not settling with fosphenytoin also, then you will go for phenytoin therapy. And then if the patient is not responding for phenytoin as well, then you will go for phenobarbital at a dose of 20 milligram per kg IV at 60 milligram per. So per minute you will be giving 60 milligram. And if the patient is not at all responding for even for phenobarbital, then you'll admit the patient in the ICU and you'll anesthetize the patient with either midazolam, propofol, or phenobarbital. You'll sedate the patient, and for the next 24 to 48 hours, patient will be in the ICU under monitoring. So this is the outline of drugs for status epilepticus. Status epilepticus can be asked as a short note. It is a very important NEET question. It is a very important viva question. So you should know the flowchart. So we basically start with lorazepam IV, followed by diazepam IV, followed by fosphenytoin IV, followed by phenytoin IV, followed by phenobarbital IV, followed by the IV anesthesia, that is midazolam, propofol, or phenobarbital. So when the patient is not responding for phenobarbital, we will shift the patient to ICU. Then you'll sedate the patient with anesthetic agent and you'll keep him under surveillance. So the other clinical advices include EEG should not be indicated for confirming the epilepsy nor for stoppage of therapy for seizure-free patient. 20% of the patient admitted with a positive recording of EEG did not have seizure disorder. So all these are the important features to be remembered. So let's see the MCQ part. So there are certain points to be remembered while treating an epilepsy patient. So what are the points to be remembered? You will tell your patient that so you will tell your patient that there are certain things to be remembered. So the certain things include make sure you're on medication on time. You're supposed to stop the drug only as per the medical advice. You're not supposed to stop the medicine by yourself. The seizure-free period is minimum for 3 years. Then only be considered stoppage of therapy. So the common failure of anti-epileptic therapy include improper diagnosis, incorrect drug of choice, inadequate or excessive dosage, and poor compliance. So first, let's see the MCQ. Which of the following anti-epileptic drugs does not act by sodium channel? So you can see the options: phenytoin, carbamazepine, lamotrigine, and phenobarbital. And the answer is D, phenobarbital. So as we already saw in the introduction chapter, phenytoin, carbamazepine, and lamotrigine, all these three drugs acts by inhibition of sodium channel, whereas phenobarbital acts by potentiation of GABA. So anti-epileptic drugs causes permanent vision loss. Here, one drug causes permanent vision loss. So this can be a potential next question. The answer is vigabatrin. So vigabatrin has an effect on eye and it is only restricted for infantile spasm. You are not supposed to give it left and right. So this should not be given because it has an effect on eye. It has an effect in the visual acuity. It can cause permanent damage to vision. So this should be consciously. It increases the GABA concentration presynaptically by acting on the enzyme GABA transaminase. Mechanism of action of ethosuximide. This is very easy to remember. There are only 3 drugs which acts on the calcium channel. One common drug is your ethosuximide. The other drug is your sodium valproate of threshold of calcium current, T-type calcium current across the cell membrane. And this is also very easy question and very important question. Ethosuximide is drug of choice for absent seizure. Which of the following is broad spectrum anti-seizure drugs? We already know the answer, right? The answer is sodium valproate. So that's it for today's class. So the points to be remembered is seizure is a very important disorder and it is commonly seen in elderly, younger group and elderly group as well. And in children, seizure is commonly seen when they have fever, they'll be getting febrile conversion. So the drug of choice for febrile conversion is diazepam. If a patient is on seizure medication, he or she is not supposed to stop the medication without medical advice. So he or she has to stop the medication only after receiving the information from his treating physician. And sudden stoppage of drug can also cause seizure. So we are not supposed to include anti-epileptic can be asked as an essay question. First generation anti-epileptics, they'll be asking phenytoin, sodium valproate as a short note. Second generation anti-epileptic is a separate short note. Status epileptic is a separate short note. And the newer anti-epileptic drugs can be asked in NEET MCQ. So this is a very important topic. Make sure you revise it as well. Thank you.